Hi, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to talk about hormone replacement therapy and how it relates to the brain. There's a lot of confusion, a lot more research needs to be done. And unfortunately, we don't have all of the answers. But today we are joined by Eef Hogervorst. She is a professor of biological psychology at Loughborough University in the UK. Eef, thank you so much for joining us.
Well, thank you for having me.
So let's just really let's start from the beginning, because I know with my friends we talk about hormones a lot. There's a lot of confusion about a drop in estrogen and how that relates to brain health. So let's just start there. What actually do we know about the relationship between the amount of estrogen we produce and the brain?
Well, so obviously during the menopause, our hormone levels have gone down. But before that, in the perimenopause, what we see is enormous fluctuations. So estrogens go up, they go down, your progesterone is all over the place. And hormones, I mean, if you think about it, hormones make you hungry, they make you sleepy, they make you lose weight, they can make you gain weight. And estrogens affect all these other hormones that do that. The other thing is that estrogens, an enormous amount of research has been done, and estrogens can really affect the brain in so many ways. So anything to do with cognitive aging, memory loss, dementia, and animal studies and cell culture studies have found that estrogens can exert benefits on that. So that's what we call the biological plausibility, and it's huge. They should really protect the aging brain. But the problem is we have observational data showing us that, yep, women who use hormones are often protected against dementia. They have a halved risk. But women who use hormones also have a lot of other characteristics that protect them against dementia. So they have money to buy estrogens, and they also have money to buy better foods. They tend to be educated, which is a huge protective factor. They have this knowledge. They eat really well. They have lower blood pressures. They are they do everything basically. They're skinnier to protect them against dementia in later life. So it's quite difficult to disentangle that. So then we need to look at treatment studies. And the treatment studies that have been done, because I did Cochrane analysis for some time, which are sort of like the gold standard meta-analysis, looking at all these studies. And so what we saw there was that hormones can improve function, memory function, speed of information processing, complex function for a very short period of time, especially in women who have a lot of symptoms. Because if you're not sleeping and you've got a lot of flushes and you feel very uncomfortable, that will impact on your ability to concentrate and focus. And so we see that for those women in particular, we see that hormones can really benefit your ability to focus again and to improve your memory. But those effects are usually in the treatment trials. So when we compare it to placebo, short term, they're only there for a couple of months. And then what we see is after a year, these effects start reversing back to baseline. And then if women are older, and they start taking these, say 65, which is 15 years after the age of menopause, we see that some women seem to actually, after that year, be getting worse. Now, in all neurons, and Professor Robbie Brinton-Diaz, who's a great expert in this area and who wrote a book with us called Hormones, Cognition, and Dementia, she found in all brain cells, if we expose these brain cells to estrogens, and if these cells have damage, which we associate with worse function, damage to the mitochondria, the little energy factories in the brain, or damage to calcium channels, which are really important in aging. Estrogens will make that damage worse. And so in 2003, the Women's Health Initiative study came out showing that in older women who hadn't been using hormones over the age of 65, who were at risk for dementia, in those women who took hormones, after a year, they started having more risk for dementia already. So this was a great shock, which is why you and I are now so confused. Like, should we
exactly. Okay, I do want to go more into those studies, but I want to back up a little bit, just because do we know exactly? I mean, you know, I know when women approach perimenopause, it's the fluctuation of hormones, and some people, it's been explained to me, some people fall off a cliff, other people it's more gradual. If you fall off a cliff, that is more risky to your brain. Do we know that? That's what I've been told, at least.
Okay, so what Pauline Mackey's group, Pauline Mackey is a wonderful expert in this area in your country, in Chicago.
And we've interviewed her before, yes.
And she worked with Dr. Weber. And what they found was that about 23% of women really have measurable problems with memory and brain function. Some women get better over that period, other women get worse. 23% really has measurable issues. And in some of her studies, she found that that was associated with worse sleep, so having worse symptoms. But to my knowledge, there aren't studies who found benefits in women who do not have severe symptoms. So it's not entirely clear what that's associated with, because if you look at the levels, so we looked at estrogen levels, it isn't that necessarily either. It's perhaps more your own sensitivity.
Right. So do we know how estrogen impacts the brain? Like, what's the relationship between the levels of estrogen we have and our brains?
Well, so if you look at animal studies where you can manipulate that a little bit easier, we see that if estrogens are withdrawn, you see massive effects. Estrogens can stimulate the branching of dendrites, so the contacts between the brain cells, the neurons. They can promote neurotransmitters, so the chemical messengers that are so important for talking, the talking between the cells, so that can affect your mood. It can affect the speed of information processing. Estrogens can affect access of blood to the brain and the use of blood and of oxygen and glucose from the blood in the brain. So estrogens, and one of the other factors that's become increasingly more important for dementia is inflammation, so low-grade inflammation in the brain, and estrogens can also protect against that. But as I said, they also have effects on all these other hormones, thyroid hormones, for instance, growth hormones, insulin. They have so many other effects on other hormones which affect your body and then affect your brain, that, you know, really they should benefit. But
okay, so on the more practical advice, a woman in her 40s, early 40s, mid 40s, approaching menopause, who has perhaps some perimenopausal symptoms, you know, maybe sweats or just difference in their cycles, should they actually consider HRT? You had mentioned that there is proof that there's shorter term benefits for people actually before they go through menopause. Is that correct? What do we know about that?
That's right. Absolutely, Deborah. I think if you are suffering, you should have a discussion with your GP. And if they don't want to go there, you should find another GP. There are lots of resources. For years, it has been so difficult to find GPs. When I went looking, my GP said, no way, you're not going to get it, period. And we're currently working on guidelines to help ease that process. And people like Davina McCall, who recently had a wonderful documentary in the UK on this topic, has been very inspirational in trying to get GPs to be easier in prescribing HRT. I think one of the problems is something you mentioned before, is the perceived breast cancer risk.
Yes.
And we really need to put that in perspective. Yes, there is a slight increase in breast cancer risk, but that's about comparable to drinking wine. Now, a lot of women are aged like a glass of wine, and they don't see any issues with that. Now, we know that slightly increases your risk of breast cancer, but it's nothing compared to the risk, for instance, of being overweight. Now, estrogens can possibly, but just a little bit out there, could possibly help you not gain so much fat around the midriff, because that's one of the things that starts happening after menopause. One of the complaints we hear most from women is that they get the fat around the tummy. And that is a big risk factor for that low-grade inflammation, for heart disease, and for dementia in later life. So whether estrogens help or not, I don't know, but what they certainly will help with in some women, quite a lot of women, about 50% of women, is they feel a lot better. Their mood improves, their concentration improves. So if you have symptoms, try it. So, it might work for you, but it's a 50-50 chance.
What are the questions that women should be asking their GPs or their doctors in order to figure out if they're the right candidate for HRT?
Okay, so there's a number of contraindications. So there are things that make it tricky, but perhaps not impossible. So in the past, if your mom had breast cancer, they would say, forget it, don't do it. Now, I think you need to be cautious, and you might want to have yourself tested, but again, it's a little bit debated on whether that should be done or shouldn't be done. I think these days, a lot of the guidelines stipulate that if there is a risk for breast cancer in the family, you could consider it, except if it's the BRCA gene, the Angelina Jolie. Sorry, BRCA gene. But if you, like my mom had breast cancer, but we're monitoring it. So I'm taking HRT, but I'm monitoring that. So you need to be monitored anyway. So I would keep an eye on it.
Should we be looking at, perhaps we need a baseline hormone prior to menopause, and should we be paying attention to how much our estrogen is dropping, or what is the indicator to determine whether or not this is a treatment we should consider?
That's a really interesting question, because hormones, of course, fluctuate over the cycle if you're not taking birth control pills. And in the years before the menopause, they're all over the place. So what would you pick? Well, I think the best way to do that, and a lot of women shop around quite a bit. A lot of women like Estrogen, which is a gel you can put on your thighs, and you can kind of regulate how much feels good. Like too much, you might feel nauseous, your breast starts hurting. You might want to reduce that level a little bit. But with Estrogen, you can do that. You can reduce that level. And the risks for breast cancer with that gel are much less, because it doesn't go through the liver. It just gets absorbed. It very much acts like your ovaries would do with a natural estrogen. So it's not like the horse urine, the Premarin.
Just to clarify, sorry to interrupt, but the gel versus a patch, or what's the other way?
No, the patches are pretty good as well. They do the same as gel, but they're perhaps less easy to, decide your own dose. I certainly wouldn't exceed the maximum dose, which is like 2 big squirts of these gels. But for instance, I myself have reduced that dose. I just didn't feel so good with the prescribed dose, and a much lower dose was much better.
Let's talk a little bit just about the type.
Sorry. The other one I'm talking about, which you probably shouldn't do, but some women do benefit from it, is Premarin. It's the horse urine metabolite derived estrogen. So it's not a human estrogen. It's an estrogen that was derived from pregnant mares. Now, I'm saying some women do benefit from it, but I've never seen that improve cognitive function in the treatment trials.
Okay, let's clarify the different, because I think a lot of people, especially if people are not on HRT, they're not going to know the difference. And so you were talking about an estradiol, right? That's one type of estrogen, which is, I thought that was the horse one. Is that or
no? No, so that's the natural one. That is your most dominant estrogen is 17 beta estradiol, and that's the one you get with the gels and the patches. So that's just
and that is a more natural. It's not coming from horses. Is it coming from humans? How is it made, or is it synthetic?
It's made to resemble the from chemicals, but it's made to resemble the exact structure as the hormone that normally floats about in your own body. Whereas the problem with Premarin is that there are many different estrogens in it. So they've gone from the horse urine derived estrogen, the pregnant mare estrogen, but there's many components to that. One of the most common one, for instance, is estrone, which isn't as bioactive. And to be fair, I mean, I've not seen a study where that actually ever did improve brain function as measured on tests or questionnaires.
So the estradiol type of estrogen, what do we know in terms of improving? Are these based on studies where women say, I'm approaching menopause or going through menopause, I have brain fog? Is that the type of symptom that this estradiol could potentially correct?
It could potentially do so. I mean, I said we've done a meta-analysis where we saw that it worked for a couple of months, so women felt better. I did a study myself in the 90s where, I mean, the difference was stunning. So women would use this estradiol. You can also take it orally, because in those days the GPs prefer to give it orally rather than the patch. And these women would be, when I assessed them at baseline, would be crying. They had memory issues. They had name recall problems. And after taking the estradiol, I was stunned. And I think, a lot of people said, why do you continue to research this? Is because as a young student 30 years ago, I saw that effect where these women were suddenly playing tennis again. They were happy. They had stopped crying, and the effect was amazing. So I think for some women they do, but we shouldn't forget that there are also about half of women who start HRT and who say, it didn't do it for me. I didn't like the side effects. My breast hurt. I was spotting, so having little bits of blood loss. It didn't do anything for me. So I think if you have symptoms, it's worth a shot. Try to get it. What I would suggest you do is first maybe try, there's a lot in supermarkets like phytoestrogens, black cohosh. You can try that, and most women.
Those are natural. Those are natural ways of supplementing estrogen. Is that right?
Yeah, you can try that. They have less of an effect, about half of the effect on reducing the flushes. Their effect on memory improvement is, but some women do find benefit, and they say it's enough. I like this. That effect is good enough.
So why is it that many women who are on estradiol or taking HRT also take progesterone? Is that related to brain at all?
Yeah. So if you have an intact womb, you have to take a progesterone. So at least half of the month, you have to take a progesterone, because otherwise your risk of developing cancer of the womb, of the inside of the womb, it's called endometrial cancer, is really high. So you don't want to run that risk. You can also put a coil in with progesterone. It's called the Mirena coil. But you don't just want to take estradiol, and your GP will, if you have a womb, will always prescribe the progesterone. Now, progesterone in the brain has quite beneficial effects in terms of that it acts as calming agents. So it acts on the same neurotransmitter, so it can make you calm and make you improve your sleep. So a lot of women take it before they go to bed, and if I take it, I sleep much better. I have a very deep sleep without getting the groggy effects afterwards. So you have to take it. But if we look at the observational data, the biggest improvements we're seeing in women over time, if there is any protective effect, and a large UK study showed that, was in women who only used estradiol. Now, those are women without a womb. And what we know is that the earlier the womb and the ovaries are taken out, the worse the effect is on dementia. So those women do have an increased risk for dementia. And they really probably, most of the data suggests, we wrote a European report about this a couple of years ago, would be suggested that they really try to reduce the risk for dementia through lifestyle, exercise, healthy diet, not smoking, but also should probably consider HRT up to the natural age at menopause, around 50. So if you don't have a womb and you can take estrogens by itself, the estradiol, you should definitely consider that. If your age of menopause is before the age of 45, certainly if it's before the age of 40. So if you've had surgery before the age of 40, your risk of osteoporosis is really high. So bone loss, bone breaks, dementia, and heart disease. So we think that for those women, people should probably consider HRT.
So if you are one of those women who are taking HRT and visibly can see the benefits of it, how long should women stay? Is this a lifelong thing, or is there a period of time that you should actually think about stopping HRT because there's no added benefits or there is increased risk?
So I'd say, I mean, looking at the data, we show that by a year, most of the benefits on brain function have disappeared. So it's very nice to carry women, I think, over that period with loss of sleep and all these symptoms. And once that's calmed down, that change to help you adapt to the next phase, you could stop it. You can stop it at any time, of course. But the data also suggests that for women using it up to about 5 years after the menopause will not increase the risk for breast cancer so much. But if you continue using it over 7 years, 10 years, the longer you use it, the more of an increased risk of breast cancer you have. So a lot of guidelines say, please don't use it for longer than 5 to 7 years. But again, this probably quite depends on your health status and your risk. It's a little bit difficult. See, if you're obese, you drink a lot of alcohol, you smoke, you have a family risk of breast cancer, you might want to be even more careful. But if you're like you're fit, you're healthy, you take care of yourself, and I've spoken to gynecologists who have people who are in their 70s and don't want to stop taking it. And so weighing up that risk and benefit is quite difficult, I think.
So you tell me exactly what we know. I mean, there's so much confusion over this fundamentally because I believe there's not enough research being done, right? And
Absolutely.
So what do we know exactly based on research studies about reducing the risk of dementia and taking HRT? To date, what do we know? And what's the current thinking?
Okay, so we wrote a book about this with all the world's experts on what can you do to prevent dementia. And basically the bottom line of that is what is good for your heart is good for your brain. So that is having that central obesity, being inactive, having high blood pressure, high cholesterol, being at risk for diabetes or having diabetes, smoking, and at various stages of your life, that risk is very much increased, especially in midlife. Midlife is probably a time when you should really do something about it, should really think about reducing your dementia risk. Before that, you can do a lot. As a youngster, you can do an awful lot of damage to your body, and there's a lot of regenerative capacity. But as we get to midlife, 45, this is the time to stop that. So you really want to stop smoking. And you want to make sure that, because as we age, unless we're very active, we start losing muscle mass and we start gaining fat. So we know that that's really important to reduce dementia risk. Now, the problem with the observational studies, which showed the reduced dementia risk, in sharp contrast to those treatment studies that only showed at best very short-term benefits, the observational studies, as I said to you, they can show benefits, you know, and especially with the estradiol only. And the problem is that women who undergo natural menopause, studies have found that years before they decide to take the hormones, they're already healthier. So they exercise, they have the knowledge, they eat well, they're doing everything to protect their heart. And with that, they're protecting their brain. So to disentangle that is like, what's causing what? You know, hormones could certainly perhaps cause additional benefit, but then why don't they do it in the treatment trials? They don't. So on some parameters, yes, some mood, some small heart effects, but it's not very consistent, that data. But on the other hand, as I said, women undergoing this early menopause who've had their ovaries taken out, those women should probably consider it, because that early loss of estrogens could be very detrimental. That could really accelerate your aging process because of the effect estrogens also have on your other hormones and your body in general.
So what next is research looking into? Like, what is coming up? I mean, unfortunately, topics that tend to pertain to women don't have as much research. This may be one example, and that's fact. But
absolutely,
what is the next phase of all of this research, and what types of answers are you looking for as a researcher?
So what we've been doing in the last couple of years was, well, first of all, I came to Loughborough because it's the most well-known university in the world for sports and exercise. It's number one. And so I came here to look at exercise programs we could develop to prevent dementia. So these are very low key 20 to 30-minute exercise to improve brain function a couple of times a week. So something that's feasible. So we've been doing that.
Do you have results that you could report to us?
Yeah, so absolutely.
What have you found?
They definitely improve memory function in middle-aged people and older people without dementia, and also in women who have undergone surgical menopause. However, we found that, so these are resisted band exercises, walking, you know, all those sort of, not necessarily having to do high intensity, but just making sure you get outside, you're exposed to the elements, you're having all that sensory input, you're moving your body is very important. Keeping your muscles strong, you know, going for nice walks. Running, some people say, yeah, you should definitely go running. I personally hate running, so I don't advocate that. But I'm sure somebody like, for instance, Pauline Maki, who is a great runner, would suggest it is beneficial.
I'm a runner, full disclosure.
Okay.
I can't live without my running, yeah.
Yeah, and I admire you for it, but I'm not one of those. So I deliberately set out to look at all sorts of other exercise other than running. The other thing that we've been looking at is effects of nutrition. And so I'm partly Indonesian, and I've gone there a lot, and we looked at tofu and tempeh because these are soy products and they
high
are
in estrogen. High.
Yeah.
Soy is very high in estrogen, right?
Absolutely. And what we found that there were some benefits of tofu in middle age, but very much like the estrogens, they were very short term. But we found another product which is consumed in Indonesia called tempeh, and it's the whole soybean, and it's fermented, and in its fermentation, it produces a lot of antioxidants, immune promoting substances. It also has a lot of fiber, so it can reduce cholesterol. We found it reduces cholesterol, stabilizes your blood glucose. And in the brain, because we tested on animals and in humans, we found that in the brains of rats where we took the ovaries out, we found that first of all, in those rats, that plaques, the amyloid plaques we see in dementia, after the ovaries were taken out, shot up. So they were at much higher risk for dementia. This is a bad sign. But if those rats were given Tempeh or estrogens, with estrogens, those plaque levels went down to normal levels. But with the Tempeh, those levels dropped way below the baseline. And so we were doing observational studies in Indonesia, and we found that the people who ate Tempeh had a much reduced risk for dementia as well.
Okay, this is fascinating to me because so much of this is lifestyle, right? And I'm so happy that science is being applied to this.
Yes.
But I think the first thing people are going to want to know is, well, how much do you have to eat, you know?
Yeah, that's one of the problems. So it might well be that that doesn't translate so well to Europeans. So it helped a little bit in our UK women. We had menopausal women, we gave it to them. First of all, Tempeh, and no disrespect to Indonesian people, I personally love it, but it tastes a bit like cardboard. So you have to do a lot to it to make it tasty. That's because of the fermentation, and it's very fibrous. So it can affect your tummy, and some people said they really had tummy upsets eating a lot of it. Now we found people need to eat 75 grams to have these beneficial effects. That's a lot.
That's per day.
Yeah. Now in Indonesia, people do eat that because it's a staple, it's a part of the staple diet, like tofu. And it's integrated. So people start eating this at breakfast sometimes already with nasi, and then, you know, so it's part of. They also, in Indonesia, people have in the guts, they have probably slightly different bacteria, and they produce something called equal, and that is highly estrogenic. Most Western people don't produce that. So the benefits we saw in Indonesian people were much higher than in the UK people. So first of all, they probably can't literally stomach it. And second of all, you know, you'd have to eat so much of it and then maybe not even have the benefits. So we're currently looking at whether we can mimic this effect, perhaps in other ways, maybe developing some sort of tablet on the basis of that, or some other treatment with some people in Singapore.
That was my next question. Is there a pill we could take that mimics it?
Yeah, I think the problem is though, see, Tempeh is such a wonderful food because it doesn't just contain the phytoestrogens, but lots of other stuff as well through its fermentation. And to mimic that is quite complicated. Yeah. We can do it, but there is so many different, there's probably over 250 different possibly beneficial compounds. Do we all stick them in? And then is it cost beneficial for industry to do that? Because if you have to source all these chemicals to stick them in your pill, are you going to get the money out? Yeah. So, you know, at the end, we're back to square one, which is you should eat the natural product, but you know, that's not so easy. Yeah. So I think for those women, you know, a lot of women try things like Menopause. I've got a tablet here, probably shouldn't show you that, but that's what it is. Menopause, it's made of sage. Oh, Menopause, this one is called, sorry, there's Menopause as well. That's made of phytoestrogens. Menopause is made of sage. Sage, you know, the herb, very estrogenic. Sage has long been prescribed through the Middle Ages. It says it to protect against memory loss. So it's the sage plant. Again, if you drink a tea of that or eat it, it tends to act on your guts. So the pills are probably better. Menopause is quite good. But again, like the estrogens, a lot of people find that beneficial for a couple of months. You feel great. It also acts on the cholinergic system, which we know is important for memory. I tried it myself. I loved it for a couple of months, and then the effect was gone. So whether your body habituates and just goes like, yeah, whatever, you know, we don't really know. But this is one of the problems, is that if you constantly bombard the body with the same chemical, it often becomes a little bit desensitized against it.
Right.
So maybe that's what it is.
Well, so Eef, thank you so much for this conversation. It's so important. And thank you too for your research in such badly needed areas for women, to turn really the spotlight on women's health issues in the context of scientific research is wonderful, and definitely need more of that. Please come back to us with more information as you get it with your research. We really appreciate scientists such as yourself really sharing this information, distilling it to the public. It's also important. And I know as a middle-aged woman, this is very interesting for me, and important as a daughter with a mom with Alzheimer's disease. So thank you so much for your time.
Thank you so much. If I may, on Wednesday, we have a public meeting, which is you can register for at Loughborough. And I'll be talking in a little bit more detail about the individual studies for about 40 minutes, and also about effects of estrogens on sexuality and mood. And that is free, so people can sign up.
So why don't you send me the link, and then I'll post it in the Facebook.
And it's also available. You can see it on lboro.ac.uk events. There should be a link there, but I will also send you a link, and then we can hopefully put it on Facebook. And people can ask questions as well if they have any.
Absolutely. Okay. Thank you so much for sharing that. We will post the link on the Facebook Live comment section. And if any of you missed part of this interview, we always repost on beingpatient.com. Don't forget to sign up for our newsletters. Our newsletters are where we post information on upcoming talks like this one. We're addressing not only dementia, but brain health, very important talks about dementia prevention and brain health. So thanks everyone for joining us, and we'll see you next time. Thanks so much.
Thank you so much.
Okay.
Thank you.
Take
Bye.
care.
Take care.
Bye.